Today, we are diving into a really critical shift in dermatopathology, specifically how we classify melanocytic skin tumors. We're going to look at a recent review that's pushing for much greater clarity and consistency, a mission, I should add, that was championed by the late Dr. Martin C. Mihm Jr., and this work is presented in his memory. So, let's get started.
So here's our game plan. First, we'll unpack the diagnostic challenge that pathologists are up against. Then, we're going to define this newer term, melanocytoma, and see how it's different from tumors with, uncertain potential. After that, we'll break down the MPATH-DX v2.0 framework, and finally, we'll see how all these changes actually lead to better communication and, most importantly, better patient care.
So what makes this field so incredibly complex? Well, diagnosing melanocytic tumors is without a doubt one of the toughest challenges in all of pathology. Getting it right, being precise, is absolutely critical for patients, and it all starts with having clear, consistent language.
And you've got to understand, the stakes here are incredibly high. We're talking about tumors that can be lethal, even when they're smaller than a single grain of rice. That's why getting the diagnosis spot on is so critical, and it's why this whole push for clarity is so important.
This slide really gets to the heart of the issue. For years, there's been this whole mess of different terms used for tumors that fall into that gray area between benign and malignant, and what that's led to is a lot of confusion, even among expert pathologists, which, as you can imagine, can directly impact a patient's treatment plan.
So to start cleaning up this confusion, the World Health Organization and other experts have brought in a new category. Let's really dig into this term, melanocytoma, and see exactly how it fits into this big diagnostic puzzle. Now, melanocytoma is not some vague catch-all term. No, it describes a very specific group of tumors that have an intermediate risk. So think of it as more concerning than a common mole, for sure, but with a very low risk of actually spreading. And this definition isn't just based on how they look under the microscope. It's also tied to their specific genetic makeup.
Okay, let's look at a major subtype here. In panels A and B, you can see the tumor is made up of these large, pink, what we call epithelioid cells. But the real key, the giveaway, is in panel D. This uses a special stain for a protein called BAP1, which is a tumor suppressor. And notice how the tumor cells have lost that nuclear staining. This specific molecular signature is what helps us define this type of melanocytoma.
All right, here's another one. A pigmented epithelioid melanocytoma. This type is often linked to the inactivation of a gene called PRKR1A. Now, what you'll notice right away is that the epithelioid tumor cells are arranged in these little nests, and they're packed with a lot of that brown melanin pigment. It's another fantastic example of how these distinct visual features can point us directly to a specific biological category.
Now, this third type is fascinating because of its structure. If you look at panels A and B, you can see it growing way down deep into the skin, almost in a network-like pattern. But the real clincher is over in panel G. See that strong nuclear staining for beta-catenin? That confirms the activation of something called the WNT signaling pathway, a super important pathway for cell growth, and that is a defining feature of this subtype.
This table does a great job of pulling it all together. It neatly summarizes the key subtypes we've just talked about, and it also includes the atypical Spitz tumor, which is now also classified as a Spitz melanocytoma. What you can see so clearly is how each diagnosis has a specific look, a known molecular driver, and a consistently low to intermediate malignant potential. It just highlights this powerful connection between a tumor's genetics, its appearance, and its behavior.
Okay, this next point is absolutely crucial. When we say melanocytoma, we are talking about a tumor with a known intermediate risk. This is completely different from a tumor where the risk is truly unknown or uncertain. So let's really break down that difference. This table lays it out perfectly. A melanocytoma has defined features and a pretty predictable low to intermediate risk. On the other hand, MELTUMP, which stands for melanocytic tumor of uncertain malignant potential, that's a term used for those really tough cases that have worrisome features but don't quite meet the criteria for melanoma. The key takeaway is this: intermediate risk is not the same thing as uncertain risk.
So now that we have this term melanocytoma, you might be asking, well, how does it fit in with all the other diagnostic terms that are already out there? This is where the second major innovation comes into play, the MPATH-DX version 2.0 framework.
Now, MPATH-DX doesn't replace the existing terms that pathologists use. Instead, you should think of it like a universal translator.
It takes all these different diagnostic labels and maps them to a simple four-class system that's based entirely on the tumor's risk and the recommended clinical action. It's a very practical approach.
So let's look at how it works. Class I is for benign, very low-risk lesions. Basically, no further treatment needed. Class II includes our melanocytomas and other low-risk lesions where a re-excision is recommended just to be safe. And then classes 3 and 4 are reserved for melanomas, which are then managed according to established national guidelines. It's a really pragmatic, action-oriented system.
I love this analogy because it perfectly captures the philosophy behind MPATH-DX. While experts might argue over the specific terminology, is this lesion a wolf or a coyote, almost all of them will agree it's not a pet dog. The framework focuses on that shared understanding of risk and the need for action, and it helps to avoid getting bogged down in debates over terminology.
So at the end of the day, why does all of this really matter? Well, these shifts in terminology aren't just some academic exercise. They have a direct and really significant impact on patient care and on communication.
You know, adopting these new systems brings huge benefits. It leads to much clearer conversations between doctors and their patients. It means benign lesions are less likely to be overtreated, while malignant tumors get the prompt, aggressive therapy they actually need. Ultimately, it just helps optimize care for everyone involved.
And so we end by honoring the incredible legacy of Dr. Martin Mihm. He really believed that using precise, data-driven language is a moral imperative in medicine. These new frameworks are a powerful step in that direction, for sure, but they also challenge us to keep asking, how can we continue to improve so that every single pathology report is as clear and as helpful as it possibly can be for the patient it serves?